So welcome to our Translation and Interpreting Research Seminar organized by the Department of Chinese Studies at the National University of Singapore. Our guest speaker today is Professor Ineke Crezee from the Auckland University of Technology. For decades, Ineke has dedicated to improving language access to health services for migrant and refugee communities in multilingual societies. A monograph, Introduction to Healthcare for Interpreters and Translators, published with John Benjamin's, is widely used and well recognized by interpreters, translators, researchers, and students. The handbook has been adapted to 7 other languages, including Chinese, and the most recent Turkish version published in 2022. And more congratulations to Professor Crezee, who is a semi-finalist in the 2023 Kiwi Bank New Zealand of the Year's Award. This is a well-deserved honor to recognize her excellent work, enthusiasm, and dedication in facilitating access to culturally and linguistically appropriate health information for vulnerable groups in local and international communities. So thank you again for agreeing to give us this talk on health interpreting and translation at this critical time when language accessibility and social inclusion have become more important than ever. So without further ado, I will leave the floor to Ineke.
Thank you, Bay. Thank you, Alex. Welcome, everybody. It's a pleasure to be here today, not quite in Singapore, but hopefully it feels that way. As Bay said, I'll talk mainly about health interpreting and health translation because that's my area, but I will also talk about legal interpreting and other areas of community interpreting because I gather that those courses are being set up or hopefully set up in the future. Now, apologies, Alex spotted a mistake on my opening slide. You can see I'm Professor of Translation and Interpreting and Translation again. But we couldn't, for the life of us, remove that second translation. So today, you can see my hobby there. It's drawing and painting. This is the coast of New Zealand, Browns Bay, not too far from where I live. Today, I'll talk about, of course, you know the difference between translation and interpreting. But I'll tell you what, in New Zealand, many people don't, and they refer to interpreters as translators. So they'll say, oh, here's the court translator, and actually you wonder where's the person sitting with their laptop typing a translation, and they mean the interpreter. So I'll explain that, but you already know. And then community interpreting, which in a lot of countries, including, to my surprise, the United States of America, is really underdeveloped. I think Australia was one of the first countries to really start looking at community interpreting for the simple reason that it's an immigration country. Then community translation, and I'll give you the definition, or sort of definition of my good friend and colleague, Associate Professor Mustafa Taibi. He's at the University of Western Sydney. And I'm co-editor of Translation and Interpreting, the international journal, but he's the editor-in-chief and he's really amazing. Well, his main work is on community translation. So I'll explain that concept too. And then, of course, my area is health interpreting and health translation. And I'll explain what strange route I took to get there. And life is actually full of coincidences. And sometimes you would think serendipity. So yeah, if you're ever feeling as if you're stuck, don't worry. The future is usually very strange, but it holds new opportunities that you never thought possible. I certainly never thought I was going to be a world expert in healthcare interpreting when I was a student of translation at the University of Amsterdam. And I never thought I'd become a registered nurse either. Then health translation is something that I really enjoy because I just love anything to do with health. And my poor students, I'm just trying to, you know, bring across that enthusiasm. I think most of the time it works really well. Then I'll talk a little bit about my research at Seattle Children's Hospital in 2014 when I became a Fulbright New Zealand scholar in the area of public health, because I looked at the difference between medical interpreters at that hospital and navigators, patient navigators, and that was for parents with very low levels of health literacy. And that happens a lot, actually. Most people are not health literate. Most people in my family, and I have a big family back home in the Netherlands, are not health literate at all. I guess I wasn't either before I became a registered nurse. So I'll talk a bit about navigators and then a bit about health translation in New Zealand during the pandemic, because all of a sudden, of course, all our communities needed access to very accurate science-based information on COVID-19 and how to keep themselves safe. But is that enough to translate things? Is that enough? And then I'll give you my wish list for, you know, what a world with very good health translation and health interpreting would look like. So, of course, you know all this. Translators deal with written material. How many translators have we got? We can't do a poll, can we? I dare not leave the screen for, for fear of doing something wrong. Well, translators deal with written material. So the great thing about being a translator, I find, is that you don't have to travel anywhere. You don't need technology as much as you need to be technologically savvy and have access to the internet and access to email, because all your jobs come through email. And sometimes people want you to work in a memo queue or something similar to that. So some sort of computerized assisted translation tool. And sometimes, of course, my students have to do written to spoken. So they might be interpreting in the hospital or in a police station, and they get given a written document and they have to read that out loud. And of course, you know that that is actually a form of translation, interpreting that's sort of in between simultaneous interpreting and translation, because you see it, but you say it in the other language. So sight translation, some people say sight interpreting. That goes to show it's somewhere in the middle. And then, of course, interpreters, either spoken language to spoken language or spoken language to sign language. As I explained to Alex and Bay just before we started, a lot of the students in my classes are actually New Zealand Sign Language interpreting students. They are doing a 3-year degree course. Most of them, upon entering the course, have no sign language. Bay, is there a problem? No? Okay, I thought you were trying to get my attention.
No, no, sorry.
They have no sign language whatsoever. And with signed languages, every country has its own signed language. Interestingly, American Sign Language is said to be very verbose. I find that very interesting because Americans are also very good at talking. New Zealand Sign Language is similar to British Sign Language and also similar to Australian Sign Language. But most of my students don't know any sign language when they come into the first year of the course. So the whole first year is spent just getting the rudimentary elements, developing their sign language. So they go on deaf camp, so they have to sign to communicate with the deaf camp participants. And every deaf person has their own way of signing. That's an added problem for interpreters, because if they're interpreting for a new deaf client, they'll have to get used to that person's way of signing first. And I said to Alex and Bay that New Zealand Sign Language only has 40 health-related signs. So sometimes deaf people have maybe, say, heart condition, and they have developed their own signs to refer to their heart condition or to refer to certain medication or procedures. And the interpreter has to find out from the client what sort of signs they use. So it's very interesting. It's different to spoken languages, where there's usually, not always, and I'll talk more about that later, usually, especially with Chinese, there is a whole lot of signs. Alex and Bay mentioned that book, Introduction to Healthcare for Chinese Speaking interpreters and translators that has lots of glossaries, and the glossaries are mainland Chinese usage, so simplified characters, but also, as you know, Chinese used in mainland China is different to how it's used in, say, Taiwan, Hong Kong, Malaysia, maybe even. And then there's a column with Taiwan and Hong Kong usage of Chinese words. So I think my Chinese speaking students say they absolutely love it. So yeah, sign language, difficult, spoken, at least for our spoken languages, we usually have a very big vocab of healthcare terminology. And then sometimes you might think, oh, what is this, signed to signed? Well, sometimes deaf people may have low health literacy levels, and so they need a spoken language to sign language interpreter, but then that sign language is still too complex, so they have another sign language interpreter that interprets from complex to more simple, less complex sign language. That's why I put that there, signed to signed. Had you ever heard of that? I'd never heard of that until a couple of years ago, actually. And of course, that can also happen at conferences because you'll have an international sign language conference interpreter, but that language is usually not understood by people in the country where the conference is. So if you're at a conference in Spain, you'll need an international sign language interpreter, and then sometimes that is then relayed into maybe a Catalan sign language or Spanish sign language. So community translation or public service interpreting and translation. Community interpreting is a term that's been used for a while. In Europe at the moment, the tendency is to talk about public service interpreting and public service translation. PSIT, public service interpreting and translation. So I tend to use both because you want to be inclusive. And both of those help people get equal access to essential public services. And I'm going to talk in a little while, I'm just going to talk about how we actually got to have public service interpreting so early in New Zealand, not as early as Australia, but certainly earlier than the United States, and certainly earlier than many countries in Europe. Because strangely enough, and Bay mentioned working with Monterey, which is actually a very high level degree offering institute, and I've spoken there as well about health interpreting, and that's also it's quite a few years ago now. They're very, very good. But that's one of the few universities or tertiary institutions in the United States that actually teaches interpreting. Most of the universities there teach American Sign Language because there is, as I understand it, is government funding for that, but not for the spoken language interpreting. And a lot of that teaching of spoken language interpreting may actually be done by individual community interpreters. So it's quite different to the situation in New Zealand and Australia and other countries. So COVID-19 pandemic, other emergencies, they often bring to the fore the importance of having community interpreters available. And I don't think I'm mentioning it in this presentation. If I do repeat myself on another slide, I'll skip over it. But in the 1970s and 1980s, there was a professor in New Zealand who had a different idea about cervical cancer to all other medical professors or doctors in the world. He thought that if you took a smear test and it was abnormal, that it wouldn't actually develop into cervical cancer. In other countries, people had already decided, yes, it develops into cervical cancer and you need to actually remove the first signs of it before it can go any further. But unfortunately, this professor wanted to check that. And so, as researchers do, he set up a massive study called the Cervical Cancer Inquiry. And he divided his groups of participants into two groups. test group, and this is shocking, but it's true, they were not going to be treated. They were just going to be followed. And then there was the control group, and they were going to be treated in the normal way. So it was going to be removed as soon as possible. But what he didn't do was have informed consent. So there was no informed consent. And so the women didn't actually really understand that they were not going to be treated. And there was also no interpreters. And many of these women were from the Pacific Islands, so like Tonga, Samoa, the Cook Islands. So they spoke a Polynesian language. And they came to New Zealand in the 1950s and 60s to work with their hands as manual laborers. And of course, didn't actually have very good English. And as someone said to me, the director of the hospital in Seattle, actually, he said, who speaks medical English? He said, even doctors don't, because they all have their own specialty. And they don't understand the medical English of other medical specialties. So how can we expect patients to speak medical English? And I'm asking, how can we expect people who've come across as migrants and manual laborers to know medical English and to know about medicine? And these women didn't. Also, in Polynesian culture, it is very rude to argue with a doctor or to even say, doctor, are you sure about that? Culture plays a very important role in communication. And so they didn't ask. So they basically weren't told, didn't ask, didn't disagree, and went ahead with the treatment. And many of them died. And this went on until the late 1980s, when two New Zealand journalists, Sandra Coney and Phila de Bunkel, had a look at that, and they were shocked, and they wrote an article for a New Zealand magazine, and it was read by many people. The government moved into action and appointed a female judge, Sylvia Cartwright, to carry out a government inquiry. That's a very serious, it's only very serious occasions when government inquiries are appointed. For instance, the mosque shooting in Christchurch, immediately a government inquiry was set up. And later I'll show you a little video clip of an interview, New Zealand TV host with myself and a former student, now interpreter, called Mustafa Derbashi. And he's actually on the royal inquiry into the mosque shooting, investigating the circumstances leading up to that. So Sylvia Cartwright led the royal inquiry, the government inquiry into the cervical cancer. How could that have happened? And she had a whole lot of findings. They're all published in her report. But the main findings were, we must always have informed consent whenever there is a health procedure that can have harmful or unwanted side effects. And we must always use trained healthcare interpreters where practicable. And that became law in the 1994-1996 New Zealand Health and Disability Commissioner Act. And there's a whole lot of rights in that law. And right 5 is the right to effective communication. And that includes an interpreter if the patient doesn't speak English or if their English is just not good enough. So even if I get a hospital appointment, I immediately get an email or a text message to say, do you need an interpreter? And my answer is always no. But I think it's very good that they do that, because they look at my name and they think, well, it's not an English name. So that's quite right, it's not. So they always offer interpreters now. So that became law. And then in 1990, the university that I now work at was the first in New Zealand to offer a healthcare interpreter course. And by 1990 also, there was the Bill of Rights. So the New Zealand police cannot interview any suspects or witnesses without an interpreter either. If they do, the case cannot go through to court because it's not been obtained in the appropriate channel. So there's legislation around the need for interpreters. So basically, any public service setting in New Zealand, you have the right to a trained interpreter, and that is a legal right. And I guess that is why interpreter training started. It had already started sort of informally in the late 1980s, but because of that cervical cancer inquiry, it then became legislation, and it really took off. So now I'm back to still the same slide. Now I'm back to why we have that legislation, and it's all about equal access to important public services, such as hospitals, the COVID-19 pandemic, the right to information in your own language. I'm going to get the COVID vaccine. What does that mean? What are the side effects? Why do I need this, etc.? And also wearing a mask, social distancing, the lockdowns, etc. So health services, also legal services, and I include tenancy tribunals that we have. We have different courts, family courts, lower courts, the district courts, and then the high court for more serious crimes. We have the police using interpreters. We have special family violence, domestic violence, hearings, and many, many others. So the government actually pays for the interpreters. The quality of the service is very important. And so recently, the government in 2017 started a whole investigation again, and they said, look, we don't think that the quality of interpreters is enough. Because it turned out that a lot of the interpreters that they were using were actually not trained at all, even though they should have been trained. And so then they set up an academic working group, which I was a member of, and they decided to go with the Australian system of accreditation. Very difficult to pass the Australian interpreting tests. So that is the National Accreditation Authority for Translators and Interpreters. The abbreviation is pronounced as NAATI. NAATI. So that is now essential. If you want to work as a public service interpreter in New Zealand, you must have NAATI accreditation, unless your language is not tested. In that case, you have to apply for credentialing. So for instance, they don't test in Slovak or Czech, the languages of the Czech Republic and Slovakia, because there's just not enough speakers of those languages in Australia. So they tend to have tests. The more speakers there are, the more likely they are to have a test. So Mandarin, of course, there is definitely testing for Mandarin and Cantonese. Malay, Bahasa Indonesia as well. The Indian languages, Hindi, Gujarati, Punjabi, Urdu, all tested. So that means that we now, as translator and interpreter educators in New Zealand, have to prepare our students for NAATI testing, and that's what we do. But we also have to prepare them for the realities of working in the field. I'm just seeing how I'm going for time. Okay. So healthcare interpreting, I always call it healthcare interpreting. Some people say medical interpreting. I don't like that term because actually the field is much wider than that. You can be interpreting for a physiotherapist, for a midwife, for a nurse. So it's wider. That's why I call it healthcare interpreting. So that means interpreting between a whole range of healthcare professionals and patients and their family members, because often they're there as well. So to me, as a registered nurse, and I'll show you my history a little bit later so you know who's actually talking to you, that includes a very good basic understanding of anatomy. Physiology. Anatomy is how the body is put together. Physiology is how does it work, and it's basic, okay? Don't think that I'm taking you through medical school. I couldn't do that anyway. And pathology. Pathology comes from the Greek pathos, which means sick. So that means all the different conditions, but actually I only teach the most common ones for each body system. So for neurology, number one at the top is strokes, cerebrovascular accidents, when, you know, you get the droopy face, half-sided paralysis. People may be unable to speak. They may be unable to move or even feel half of their body. It's either caused by a clot in an important blood vessel in the brain, or sometimes in the neck, the carotid arteries. Very occasionally, it's caused by a rupture of a blood vessel. So it's a bleed. That's number one. So I always teach that. So I don't teach a lot of very obscure conditions, but the most common ones. So they'll also be in the book. And as I said, I've got sign language interpreting students. They don't have signs. I've got students that speak Polynesian languages and they don't have words. They, for instance, may have one word for backbone, spine. They don't have a word for vertebra. You know, you have these vertebrae in your spine, in your neck, the cervical vertebra, then the thoracic vertebrae, etc. And so they don't have a word for the little discs in between the vertebrae, which are called intervertebral discs. And so all those things they have to unpack. One of my students, she has a Chinese name. She was brought up by her Chinese granddad. Her name is Hoineng Wong Soon. She absolutely loves health. She is a very good health interpreter and translator. She was in hospital with her stepdad, who had advanced lung cancer. And the doctor said to him, he had problems breathing. The doctor said to him, "You have malignant pleural effusion." The interpreter didn't know what that was. So Hoi said to the patient, she said, "You have a lot of fluid in your chest where your lungs are because of the seriousness of your lung cancer at the moment." He understood that. The charge nurse was standing next to the doctor and she was Samoan. She went like this. Perfect. You can only unpack it if you understand what it is. Malignant pleural effusion, I mean, gosh, you know. I didn't teach Hoi that word. I taught her the basics and she developed her own understanding by reading and reading and reading. So NZSL that you see on the slide means New Zealand Sign Language. Our students, health interpreters and health interpreters must also reflect on their own cultural upbringing. For instance, as a Dutch person, I'm very aware of the fact that in the Netherlands, we're very direct, way more direct than English speakers, maybe as direct as Chinese speakers. I don't know. My husband used to have people ringing up and he learned Chinese. And people ring up and go, "Paul, zai ba zai," and I would say, "Ba zai," and they'd go, "Okay, bye-bye," boom, and they'd put the phone down. In English, you couldn't say that, right? You'd have to say, "Paul, is Paul, oh, excuse me, may I speak to Paul, please? Oh, I'm sorry, he's not home. Oh, okay. Can you take a message or I'll try again later. Thank you. Bye-bye." So it takes a lot of time, right? So every language is different. You need, as an interpreter, we need to be aware of how our language operates, but also in terms of culture. One day I was interpreting for a Dutch lady from the Netherlands, and she had had a bypass operation 8 years before she came to New Zealand. Now, one of the bypasses was blocked. The doctor said he was from India, but he was working in New Zealand. He said, "Okay, Mrs. So-and-so, you can go back to the Netherlands." And she said, "Excuse me? Back to the Netherlands? You must be joking. I've already got one blocked bypass. What if I'm on the plane and the other 3 block? I'll be dead." She said, "How dare you even suggest it?" He was so taken aback. He's like shocked. This whole argument erupted. Eventually, the lady left. And the doctor said to me, "Are all your patients this assertive?" And I said, "Well, people in the Netherlands are very assertive and they tend to have good health literacy. And so if they don't agree, they don't care that you're the doctor. They'll just tell you, 'I'm sorry, I don't agree with that.'" And he said, "Well, I'm not used to that." So we need to be aware of that. Sometimes that we will actually be asked. So we need to be able to reflect on those intercultural issues and also on our own ideas. we also need to look after ourselves in terms of self-care, because very often, without warning, what we are interpreting in the first person may be very traumatizing for us. It may be a case of a woman who was severely assaulted, maybe sexually assaulted, maybe physically assaulted, and she's at the police station, and the police like to get the story straight away when the wounds are still fresh, the mental wounds as well. They want to get that story straight away because they know people's memories operate best when it's just fresh in the mind. And so they'll ask questions. We interpret them in the first person. We interpret horrible situations. And we need to be aware of the negative impact that can have on us and be aware of the very first signs of trouble. I've written an article about that with a psychologist, a Chinese psychiatrist, and a Chinese mental health nurse, about the first signs and what we need to do to keep ourselves safe. And this went for interpreting during lockdown as well. When we were isolated, we couldn't leave our houses. And so we couldn't actually talk to anybody, which is difficult anyway, as you know, because we have to maintain confidentiality. But self-care is very important. I said before that we are now preparing people for the NAATI interpreting tests. Part of that, very, very important part of that, is discourse management. Discourse management actually means that you keep the interpreting manageable because you interrupt at a natural pause. You don't let people go on and on and on, and your memory is overloaded and you can't remember anything, even if you've tried to take notes. And of course, we all know with consecutive interpreting, you either really focus or you take notes, but it's very difficult to do both. I mean, I always try and do both, but sometimes I look at my notes and I think, what was I actually trying to write there? It doesn't always work. So NAATI teaches people, and we teach people to stop. So at the start of the interpreting assignment, say, my name is X. I'm your Chinese interpreter today. Everything that is said here today will be kept confidential. I will interpret everything that is said here today. Some people add, and I think it's a good idea. If there is anything you do not want interpreted, please do not say it. Right? Because we always get people talking in asides or family members, and once you've said that, just go ahead and interpret it, which is, I think, what you should do anyway. And then the other thing that you should say is, I may stop you from time to time to help me interpret. I'll do that by putting my hand up and going, one moment. Say it in both languages. Explain your role in Chinese or Malay or Arabic as well, so that both know. So I think in Chinese it could be one little wait. I don't know how to say it in Mandarin, but Chinese speaking colleagues told me how to say it and I've already forgotten. I apologize for that. And then, of course, for working in the hospital, we need to understand how the system works, what the procedures are. And I tell you, once you've interpreted once for somebody getting a heart catheter and they have a look at the heart and they put contrast dye in, you know. So the procedures we need to be familiar with, the roles of different staff, who is higher. In our hospital system, the consultant is the specialist. He's the highest doctor. Below him come the registrars. They are training to be specialists. And below the registrars, we have the junior doctors. They're doing 2 years after medical school before they specialize or maybe become family doctors. So there is a hierarchy. We need to be familiar with that. We need to know who we're interpreting for. And then strangely enough, and I don't know if this is true for Singapore, but in New Zealand, health professionals use a lot of informal, idiomatic language. And I'll give you examples of that later as well, because I've done quite a lot of research on that. Because, of course, students, when you know what it's like, you learn English, you learn formal English, right? I learned formal English at university in the Netherlands. I've got a master's of English and a master's of translation studies. I never learned informal language. And yet in New Zealand, the doctors use it all the time, and the paramedics and the nurses. I'll give you one example. I was interpreting I was just looking after a patient, and the person had problems with their kidneys. And so I said, I need to measure your urine output. I said it very formally because that's what I'd learned at university, right? The doctor, he was a young Chinese doctor. He was born and brought up in New Zealand, so he spoke like a New Zealand person. He plonked himself down on the patient's bed. Can you imagine someone doing that in Singapore? Just sat down on the patient's bed and said, "G'day, how's your waterworks?" And I thought, goodness me, waterworks? Are you kidding me? We're talking about plumbing here? But the patient understood it, and he felt relaxed and at ease. And he answered the doctor because he thought, oh, this guy understands me. So doctors in New Zealand, nurses too, tend to be informal. There's a lot of challenges to healthcare interpreting, and I've done quite a lot of research on that. Always trying to prepare my students. So almost everything I do is aimed at finding out what's actually best for my own students, and I feed it all back into my classes. So health professionals very often do not understand the interpreter's role, and they say they're too busy to learn. So I used to give lectures at medical school, the University of Auckland, but they stopped those, and it's a real shame because they were quite fun lectures. And I thought it's essential. Keep your sentences short, etc. Speak in plain English if you can. Not all doctors can explain things in plain English. And don't ask interpreters to make the patient a cup of tea or to wheel them to the toilet in a wheelchair. Please don't ask interpreters to do that. It's not their role. Very often doctors and other professionals, immigration officials, judges, don't get me started on judges, they use very long sentences and they don't stop. And they think that we are these amazing robots, perhaps, that can remember all these words and interpret them into another language. We can't. So we have to manage the discourse. We have to say, I may stop you from time to time to help me interpret. So I think discourse management is a very, very important thing. My colleague, Dr. Miranda Lai, she's originally from Taiwan. She's at RMIT University in Melbourne. She taught me how to teach interpreters this. So thank you, Miranda. So there's more challenges. The challenges also come from the patient's family, because sometimes, of course, the patient's family does not want us to interpret, especially not bad news. And New Zealand is a country where the patient is central. It's the individual. It's not the family. So the patient gets told what's wrong. The family may not want that. So very often the family will actually stop the interpreter outside of the hospital room and say, please leave that out or change it. If they say lung cancer, can you say bronchitis? And the interpreter has to say no. But if you want to ask the doctor, we'll wait for the doctor. You speak to the doctor and I will interpret between you and the doctor, but I can't leave it out because that would be unprofessional. It's against our code of ethics. They have to be accurate. And so for that reason, sometimes family members insist on interpreting themselves, and then they have control. And the problem with that is that, of course, they have no knowledge of anatomy, physiology most of the time. They may leave things out. There is a very, very good video clip by Anna Kelly in Australia. I think she's in Sydney, where they have a young boy interpreting for his mum, and the doctor says, have you had any terminations of pregnancy? So that's where the pregnancy is terminated by the doctor, and she's had 3. She's not going to say that because her son is interpreting. She doesn't, so she says no. But actually having had terminations of pregnancy has implications for fertility, possibly for pregnancies. So it's an important question and it needs to be answered honestly. And if there's a family member interpreting, you won't get the honest answer because the patient may feel too embarrassed. They may not want to disclose that. So who educates the health professionals and the health consumers about the interpreter role? I don't know. Some hospitals do, so they're good. And in those hospitals, the interactions are way more smooth. But a lot of hospitals don't. So that's a real issue, and nobody educates the family members. So that's why it's so important for all of our interpreters in New Zealand to just explain the role in both languages at the start. Even if the doctor says, oh, I'm in a hurry, I'm in a hurry, I'm in a hurry. No, doctor, I need to explain my role. Very important, because otherwise you get all those issues. So this is just some of my research because you're studying. So I thought you might like to know what I've been doing. So you can see Introduction to Healthcare for Interpreters and Translators, lots of different languages. 2016 was a busy year. We even did Korean, but that was published by Hankook University of Foreign Studies in Seoul. And I think you can get it through the Monster bookstore in Seoul, but it's, unless you know Korean, it's difficult to find online. Then situated learning, reflective learning, interpreting in refugee settings. There's the self-care for interpreters that I spoke about, health interpreter role expectations, interpreting and translating during the COVID pandemic. And I did that with Miranda Lai. She's in Melbourne. And then there's a book coming out about how we all have to change our ways of teaching, interpreting, and translation during the COVID-19 pandemic, because a lot of universities had to move from on-campus teaching. I don't know what it was like in Singapore, but we had to move to remote teaching. Fortunately for us, we were already teaching remotely. And so the step for us was actually quite small, but for a lot of colleagues teaching other courses, it was really big. So we had an advantage there because we had already had students joining us, New Zealanders joining us from overseas, from other countries. So we were used to it. So health translators. So what are some of our challenges? I don't know if it's just me or clients always sit on their hands, you know that expression. They wait until the last possible minute before they say to you, actually, I need a translation. I don't know. They seem to think that we can just go finish, and we can't. So we get impossible deadlines. So the first thing, if you're a translator, you need to say, look, I can't make that day, but always, this is my advice, and I've had 40 years practice as a translator, always say, I can't do today, but I can do Monday morning. So then you have the whole weekend. I translated my first novel when I was a very young student at the University of Amsterdam. So that's why I have that much experience. That was actually really good. It's called situated learning because you learn, we got all the theory, but then you learn more from doing yourself. So I translated a whole book whilst I was studying. I did it in 3.5 months. And I didn't want to read the book for ages because I was afraid that my Dutch was so bad. So a lot of health translators, they take on the job for the money, but they actually have no idea about anatomy, physiology, pathology. And sometimes the language that they create for their readers, so in Chinese or in Samoan, will be really bizarre. Hoi Nang said to me yesterday, she said, oh my goodness, Ineke, I've just found out there's a Samoan translation on an official website in New Zealand. And instead of antibodies, she said, I unpack it as special proteins that help your body to recognize intruders and make special, you know, they have special weapons to deal with those intruders. She says on that official website, it's like a sort of lemonade. She said, this is the translation. Unbelievable. So the person had no clue and just translated something completely wrong. And sometimes it's just very unnatural language because I don't know if it's the same for you, but after you've been in a country where your language is not spoken at all for a while, you cannot actually produce natural language in your own mother tongue anymore. So you need to always ask someone to read it again. And the end users are not usually involved, especially if there's a rush. We need to get a COVID translation out there, COVID-19. we don't have time to ask the end users, and yet there may be culturally inappropriate things in there. For instance, in New Zealand, Hoinang found, she and I just published the chapter. It's called Speak My Language. And she found that the word for masks, facial masks, during COVID, the Samoan translator had used the word for covering the face of the dead. So special cloth gets put on people's faces when they have died. And that was the word the translator had used for mask, which was supposed to keep people safe. Instead, they got this association with passing away. Most unfortunate. So you can see that a lot of my research has centered on preparing people for translators and interpreters to do their work, especially in the healthcare setting. So how did I become involved in this work? Now you've listened to a lot, and I'm going to now entertain you for a bit. So relax a little bit. So we're going to go back in time. So that's me as a 5-year-old. That blonde girl with the scooter, that's me. When you're blonde, your hair goes darker as you get older. Unfortunately, it's always the case. Very occasionally it doesn't, but for me it did, unfortunately. So I was 5, and I lived in a tiny village. My father was a police officer. My mum was a registered nurse. And I, as a 5-year-old, was really interested in languages. Don't ask me how, because it was a tiny village. Nobody spoke another language, except my mum. She was learning English with a course. I still remember the name of the course. It was called Walter and Connie Reporting. And she had little books with it. So I started reading the little books. Again, don't ask me how, but you know, when you're a little child, you read something in another language and you understand it. It's really bizarre. Anyway, so I got to know there was English, French, German, and Portuguese. I knew about Portuguese. So I kept saying to my sister, I wonder what poo is in Portuguese. I wonder how to say poo in English. Because, you know, when you're 5, you have a fascination with language, with words you're not allowed to use, toilet words. And so we have a special festival on the 5th of December, and it's called St. Nicholas. And St. Nicholas will give you things that relate to what's happened that year. St. Nicholas gave me a toilet made of chocolate and with a little poo in it, and that was a lolly. That was a candy, a sweet, right? So St. Nicholas must have heard me. Of course, that was my mother. Okay, you realize that later. So I then had the very great luck. We have a school in the Netherlands. It's called Gymnasium. Nothing to do with bodybuilding. It's like a German school, Gymnasium, they call it in Germany, and you learn a lot of different languages there. So I learned Dutch, of course, Latin and Greek. We had to read a lot of Latin and Greek and translate it very literally. And I learned French, German, English. I taught myself Italian. My sister was learning to read the Bible in Hebrew. So I thought, okay, I can't be behind her, you know, sibling rivalry. So I started teaching myself Hebrew as well. And at the same time, I was starting to read the newspapers and starting to draw cartoons for the national newspaper. So there's these two things: love languages and I like drawing. And I'll show you a drawing later. My father at the time was teaching at a police academy, and he must have been a really interesting teacher. He passed away 4 years ago now. Bless him, he was almost 92. He must have been a really wonderful teacher, because when he passed away, we got contacted, my brother and I got contacted by students of his. They said he was just amazing as a teacher. Everything he taught, which was boring, traffic law, he made it so interesting. I remember one day I came home from school and my father had all these toy cars on the table. And I said, oh, great, toy cars. He said, not for you. So not for me, not for my brother or my sister. He said, what are you using them for? He said, to teach traffic law. So that his students in class would create collisions and have roads. And then he would say who was in the wrong, what traffic law applies. Not only that, the school, the police academy, was in a huge, like a mansion and lots of grounds around it with roads. And so he got people to bring their own cars and pretend that they had a crash. One person had to be one driver, another student had to be another driver, and a third student had to be the police officer. And he had to know the law because he had to apply it. So he made his classes fun. And that's what, when he passed away, that's what his students said. They said he was just amazing. Also, my mother was working in an operating theatre, and she loved explaining things. I think I have it from both parents. And so she was teaching people in the operating theatre. This operation is cataract operation. You need these instruments. This is how you clean the instruments. This is what the doctor's going to ask for first, etc. So the use of little cows and real people is called situated learning. That's a very old way of learning. People used to learn to be a carpenter by becoming an apprentice. I think that's actually the best way to learn, because if you learn from a book, it's very difficult to remember. I'm sure that you've all tried to just memorize things from books. It takes a long time, and it doesn't really stick in your mind as it would if you had been through that situation yourself. So situated learning is a very good way to learn. Here's some of my political cartoons. They appeared in national newspapers. Unfortunately, I didn't get money for them. I got book vouchers. So I bought a lot of books with these, with the money that I earned. So it was all political. I couldn't do it now, actually. I probably don't follow politics enough. Then I went to the University of Amsterdam. After school, I wanted to become a registered nurse. My mum said, no, you're the top student. I was the top student at school in my year until my brother came a couple of years later and he smashed all the records. He became a medical researcher. But my year, I was really good. I had a lot of languages, so I had played to my strength. I had to take mathematics, but I took a lot of languages, and I loved languages, and for some reason, I remember them very easily. So Mum said, no, you can't become a registered nurse. So what else do you want to be? I said, interpreter. She said, oh, you can only become an interpreter in Switzerland or in Belgium, and we don't have the money to send you there. But the University of Amsterdam offers translation studies. I thought, okay. So I studied translation studies at the University of Amsterdam, and that was actually established to have better translators of literature. We had James Holmes, who was quite a famous translation theorist, and even in the second year, we started to translate a book together with the other students. So we learned by doing. That's situated learning, theory and practice. After studying translation studies for 4 years, I did a bachelor degree in English language and literature. And then after that, I thought, right, that's it. Now I'm going to become a registered nurse. And I didn't want to do that at university. So I studied that at a big hospital. And this is the big hospital in Amsterdam. It's a general hospital. The patients were from all over. They spoke all sorts of languages. So I learned Turkish. I had to go at learning Arabic. It was too difficult. And I had to do my first health interpreting jobs in that hospital, not between English and Dutch, but between Spanish and Dutch. Spanish is my third language. So that was very interesting. I had to interpret during operations sometimes, you know, when there are people under epidural anesthesia. So they're just paralyzed from the waist down. And I had to interpret with Spanish between doctors who spoke Dutch and patients who spoke Spanish. Very interesting. And in the hospital, I learned to be a nurse 3.5 years through doing. We had classes, but most of the time we were actually applying what we'd learned. That is also situated learning. And my colleagues were very collegial. So I really loved that. I always think that's the best thing I ever did. And I tell you what, when I finished nursing, my mum was super proud. I think she was prouder of me then than after getting my bachelor or my 2 masters. So yeah, she was very proud of me. All right, so I did a BA and MA English at the VU University in Amsterdam. That's another big university in Amsterdam. There is 3 universities there now. There was only 2 there at the time. So you can see that house on the canal. That's where the Institute of Translation Studies was. Yeah, I liked drawing, as I said. So this is actually a board game, and all those people in the pictures worked in the hospital. And when I look at them now, I actually recognize them. For instance, this guy here, he was a surgeon. I think he was an orthopedic surgeon. And this guy here, he was head of restaurant services. So that's why he's offering a cup of coffee. And this is important because it comes back to some of the research I did later. So I had academia, MA English. I wrote my thesis on corpus translation. MA Translation Studies. I did research on nursing translation, nursing research. My PhD was on language use amongst older Dutch migrants. And after that, since then, I've been researching interpreter-translator education because I wanted to benefit my students. So that's academia. The School of Life. I worked in a post-anesthetic care unit. I worked in a special care research unit for stroke patients. I backpacked through Asia for 9 months, spent 4 months in China in 1988 till January 89, lived in Hong Kong for 2 months, went through Malaysia, Singapore, Indonesia, and then arrived in New Zealand, and they said, oh, you can't teach English because you're not a native speaker. And I thought, good grief. I've learned so many languages. I think at that stage I'd learned 14 different languages. I thought, I really know what it's like to learn English. You don't, because it's your first language. So if I can't teach English, I don't know who can. Anyway, so I had to work as a nurse. And then I started working as a part-time lecturer of healthcare interpreting and changed the way health interpreting is taught in New Zealand. And hopefully that is now actually coming through in other countries as well. So I was Auckland branch president of the New Zealand Society of Translators and Interpreters. And I wrote the blue book, which I'll show on the next page, from 8 to 11 p.m. every night. I had 2 little boys. They were 1 and 3 when I started, and they were 3 and 5 when I finished the book. So I'd put them to bed, read them some bedtime stories. I'd go into my office and I'd work on this book. And what sort of book was this? Well, there it is. You see, that's the first version. That's the pre-runner of these books. I had a Vietnamese student, and she said to me, there is no book for healthcare interpreters. And so I thought, oh gosh. So I said, what about this book? She went to the bookshop, she had a look, she came back, no. What about this book? Okay, she went to the bookshop again, she came back, no. And at that stage, I said, well, what sort of book are you looking for exactly? And she said, look, I'm already working as a health interpreter. And what I will get is, okay, cardiology, 9 o'clock tomorrow. And she goes, I have no idea what that means. How can I prepare? I don't know anything about cardiology. So, or they might say endocrinology, 4 o'clock tomorrow. What does that mean? How can I prepare? So she said, what I want is a book that's got chapters: cardiology, endocrinology, orthopedics, neurology. And then for each chapter, say for cardiology, the chapter cardiology starts with, this is the heart. This is what it does. This is what it looks like. It's got 4 chambers. It's got the aorta coming out, got the pulmonary artery. And these are the main conditions to do with the heart. This is what the doctor will ask. These are the investigations the doctors will do, and this is the treatment. And I thought, oh, golly, gosh, she's right. There is no book like that for interpreters. So that book, the blue book, took me 2 years to write. And then in 2012, some professors in Australia said, oh my goodness, Ineke, that blue book is totally amazing. I thought, really? Australians think that my blue book is amazing. Professors in Australia think my blue book is amazing. Professor Sandra Hale thinks my book is amazing. Aldous Ozelens thinks my book is amazing. And they said, can we order 40 copies? And I said, sure. So I sent up 40 copies and they used them. And then I thought, oh gosh, I have to offer this book to a publishing company, because it has to be marketed. I can't market it. I'm just a single person. And I have to update it. It has to be internationalized. So I sent the book to John Benjamin's. And normally, apparently, they take a long time to get back to you. With my book, they said the same day, they said, wow, thank you for offering to publish this with us. How long will it take you to internationalize it? I said, a year. So I took a year, and so that book in the middle came out in 2013. And I think that's Russian-speaking interpreters and translators. So that book came out in 2021. Actually, the Turkish book came out in 2022. So Chinese came out in 2016. Right, a backpack through Asia, came to New Zealand. I told you I wasn't allowed to work as an English teacher, so I started working in this big hospital at the bottom here. It's called Middlemore. It's in South Auckland. It's the most diverse area of Auckland, most ethnically, culturally diverse. Lots of speakers of different languages. And that's actually where the very first interpreting service was set up in 1991, healthcare interpreting. At that time, they dealt with Polynesian languages. And I told them, I said, within 2 years, Chinese will be your most in-demand language. And they laughed at me. Guess what? I was right. It's still the most in-demand language in New Zealand. It's the #1 language. We have the most interpreters for Chinese, but it's also the most in-demand language. I started developing healthcare interpreting courses from 91 and worked for the Southern Cross Healthcare Line. It's a big insurance company, and they had a healthcare line. People would ring up and say, nurse, I'm going to have this operation. I have no idea what that means. So we would explain it to them over the phone. I loved that job, actually. And I wrote the Blue Book. And then established interpreter education at another institute from 96 to 99. And then AUT, where I am now, they headhunted me back because I'd been there for 3 years in the early 90s. And they said, can you please come back? So I'm still there now. Aotearoa is the Maori name for New Zealand. And it's a very diverse country. There's an ongoing need for interpreters in all sorts of interpreting settings because it's the law. And so in 2019 and 2021, the top 10 languages, you can see again, Mandarin is at the top, Cantonese is second, and that's actually unchanged. I've seen the numbers for 2022-23. Mandarin and Cantonese are still the most in-demand languages. And then in the top 10, we have Samoan, that's spoken in a small island of Samoa. Tongan is spoken in Tonga, that's a Polynesian language. We have Korean, Arabic, Spanish, Hindi, Punjabi, and Portuguese. And Hindi and Punjabi are still in the top. It's also because for a while, people were allowed to take their elderly parents with them. I think that's no longer the case. And so, of course, you know, people get older, they get more health issues, and they don't speak English, so they need healthcare interpreters. How are you going? Do you need a little break? Because I can speak for hours. Bae?
I think so good. It's up to you. Do you need a break?
No, I'm fine. I can honestly, I tell you what, another little funny story.
Yeah.
I had a Japanese student in class once. And Aki, I still remember her, and she was sitting in the front row of my health interpreting class. And I said to the students, I really admire you because, you know, it's so hard for you. It's easy for me. All I have to do is talk. You have to sit there and listen. That is difficult.
We enjoy it very much. That's my cool story. Thank you for sharing this with us.
And Aki said, what? She said, unbelievable. She said, in Japan, the lecturers tell us how difficult it is for them and how easy we have it. All we have to do is listen. I said, that's not easy at all. Talking is much easier than listening. So that was a huge cultural difference. But you can see, yeah.
No, and then, I was just thinking, all audience are still with us. We didn't lose any of them. So please.
It is hard to be a listener. So you can see, looking at all these languages, you can see that we have a big need for language specific. I can actually read the screen without my glasses. I only need them for reading. For non-language specific interpreter education. So that is a bother though, because I know in Australia, they now have non-language specific translator interpreter education, but they never used to. They always used to have, say, a class with a Chinese tutor, a class with an Arabic tutor. And of course, Chinese classes, they would run year in, year out. Arabic, maybe, I know University of Western Sydney always have Arabic classes because that's where Mustafa Taibbi is. But say for Vietnamese, they might say, okay, you want to do Vietnamese? Wait till 2 years from now. We will have Vietnamese tutor. So they would offer languages, but not every year, except for the most in-demand languages. In New Zealand, it's always been non-language specific. So the poor students, again, I always feel sorry for the students. What are they going to do? Where are they going to get their feedback from when there's no money for Chinese tutors? There's no money for Spanish tutors. So I devised this system whereby students do an interpreting task on GoReact that gets posted on Canvas. It's our learning management system. And then everybody can see, oh, Susie has done her GoReact of Dialogue 1 or monologic simultaneous interpreting task 1 or long consecutive interpreting task 2, whatever Susie's done. And then Bay and Alex would go, okay, well, Susie, we also know Mandarin. So we will give you feedback in GoReact on your task. And then in return, Susie gives Alex and Bay feedback. But she also reflects on how she thinks she's done. And very often how we think we've done is not how other people judge our performance. We all give different feedback. So that's what I've been doing for years. I've done compulsory. I've had to make it compulsory because if people don't get marks for it or a percentage of the overall grade, they don't tend to do it. All right, so that's why it's non-language specific. Now you see a map of New Zealand here. You see the two main islands, the North Island and the South Island. At the moment, I don't know if you can see the cursor, but I'm somewhere around here. Can you see my cursor? I'm somewhere around the low part of the North Island. But Auckland is sitting just underneath that long bit at the top. That's where Auckland is. It's a harbour. It's got 2 harbours and it is the biggest city of New Zealand. It's got 1.5 million inhabitants. You probably laugh at that in Singapore, but the total population of New Zealand is only 5 million. So that's the biggest city. I think Auckland has as many inhabitants as the whole of the South Island. If you're ever going to go to New Zealand, I tell you what, the South Island is absolutely beautiful. The North Island is beautiful too. The South Island, I think you would probably enjoy more. Do you drive on the left? Because we drive on the left, so that's it's important to know. So yeah, so Auckland is here. I mentioned situated learning, and you know now from me that I like to use all sorts of ways, just like my dad did with the toy cars, to make the learning more interesting. But also for sign language interpreters and for people who speak languages that haven't got medical terms, it is very important to see the body parts. And for me, it is better if those body parts are in 3D. So I've actually got a spine like that. I've got that model. Does anybody know what that thing at the bottom is? I'll give you a clue. We have a lot of asthma in New Zealand. You can put it in a chat box and then Bay will tell me what you wrote.
We don't have any guests right now, but we do have some information about in Singapore. We also drive on the left side. So to answer your previous question, yeah.
That's good. And what's the thing in the bottom left? What is that?
Any guess?
Does anybody have asthma? Then you know.
Probably not.
Nobody knows. Nobody has asthma. That's very lucky.
Oh,
It's
someone said like a spirometer in
Yeah, it's a
color.
peak flow meter.
Yeah.
So
Right.
you put your lips on the other side, the side that's furthest away. There'll be a mouthpiece, and you go, and then the ruler will shift and show how much air you are able to breathe out in milliliters, cubic milliliters. I don't know, milliliters, I think, in one go. And then if you check that all the time, you can see how bad your asthma is or how good your asthma is or whether you are controlled or not. So it's called peak flow, P-E-A-K-F-L-O-W, peak flow, a peak flow meter. So every person with asthma should have one. What about that tubey thing in the top right corner? What is that? I got that given by a student who was working as a nurse. And I said, I actually want to have one of those. And she said, oh, I will get you one. It's called a catheter. I think I've got it on the Realia. If you look on the right side of the screen, you can see Realia, a heart catheter. That is a heart catheter. The doctors will make a small cut, very often still in the groin, and then they push that catheter up through the groin artery into the big body artery, which is called the aorta, and then until they reach your heart, and then they go into one of the arteries that goes around the heart. Those are the arteries that bring oxygen, nutrients, blood to the heart muscle itself on the outside of the heart. Unfortunately, with stress is really bad for your blood vessels and your heart. Stress is as bad as smoking, they say. So if you're smoking because you're stressed, it's probably a double problem. If you have diabetes, you should never smoke. Diabetes is also bad for your arteries. But anyway, if you have any of those problems and the doctor wants to have a look and see how healthy or unhealthy, how blocked or unblocked your heart arteries are, your coronary arteries, they will push that catheter into the coronary artery, one of the arteries around your heart, and then they will use that second opening that you can see in the top of that picture, not the orange one, but the other one, to push some iodine in. When you then take an X-ray, you can see the iodine filling the arteries, and you can see how open they are or how narrow they are. So you can see where the narrowings are, if there is any narrowings. So that's very, very important. I bring that to the class because then the sign language interpreters can see how thin it actually is, because our arteries are not very big. Inhalers, I bring to the class, peak flow meters. Oh, that's right there. 3D models of the heart, the eye, the brain. I bring all those things to the class because I think it's very useful for the students to see those. So I have all these. I have this little man, you can see his lungs, his bowels, his stomach. You can see his liver there. The eye, very complicated. Chinese interpreters in Auckland always seem to be at the eye clinic. That's one of their most common appointments for older Chinese migrants, is eye issues, not just cataract, but also glaucoma and other issues. You see the heart there, you can see the red arteries around, those are the coronary arteries. They're the first ones to come out of this big red artery here, that's the aorta. The very first arteries with the freshest blood go straight to the heart muscle itself, because that is so crucial. I don't know about Singapore. We have a lot of people in New Zealand with joint problems. You see the bone. I think that's actually, I think the blue is supposed to be the cartilage, and that tends to wear away if people are overweight or if they do an awful lot of running. That cartilage may wear away and they may need a joint replacement. And then you can see the lungs, the trachea or trachea, people pronounce it differently. And you can see the lobes of the lung. So I bring all those things in and pass it around the class. So Idiomatic language. Clam up, a wolf in sheep clothing. The dog days of summer. Goody two shoes. You're the top banana. Is green with envy. A wild goose chase. There is so many idiomatic expressions used by doctors, nurses in the UK, in Australia, in New Zealand, and the students, my students, I myself didn't know them when I came to New Zealand. I know them now because I'm married to a New Zealand man, and he uses them all the time. So that was very good for me. So my students are mainly skilled migrants. They've done a degree, say in Singapore or mainland China, in Hong Kong, in South America. So they're well-educated people, but English is their second language. They've learned formal English just like I did. And then unless they work in New Zealand, they are not going to learn informal English. You learn that either in context or by watching New Zealand programs like Shortland Street. Shortland Street is about a clinic, a health clinic, and they use idiomatic expression all the time. Unbelievable. I wonder how people understand that program if they're not from New Zealand. Yet, if you watch it, you'll see the idiomatic expressions used in context and you'll learn them. But over many years, I always wrote dialogues, practice dialogues, and I'd put some idiomatic expressions in. And then I'd be in the computer lab and the students would come up to me, Ineke, what does that mean? He was on tenterhooks. What does it mean on tenterhooks? It was always the idiomatic expressions that they didn't understand because they learned the medical terms in class. So they were not a problem. They looked them up, but it was the idiomatic expression. So I thought, okay, I have to try and do some research to find out what the problem is there. So I got some money from the faculty and I did some research and I showed the students clips of paramedics talking to patients and using idiomatic language. So here's a couple more. So barking up the wrong tree. He was on cloud 9. Oh, they're just crocodile tears. Oh, I heard it through the grapevine. Don't get on your high horse, etc. Oh, I'm going to hit the hay. Go to bed. I send him on a wild goose chase. Oh, he's a smart cookie. Oh, how are you feeling? Oh, I'm a bit under the weather. What? Okay, so I showed the students video clips and they got stuck on those. Even give me a hand. Some students interpret it as give me your hand, give us your arm. Or can you give us your hand? Not can you help me? Can you give us a hand? Give me a hand. Interesting. So these are some of the publications on healthcare interpreting. This is Yunduan Gao, Eunice Gao. She was my PhD student, one of my PhD students, I should say. Very, very good lecturer. She taught with me last year as well. So that's on teaching non-language specific health interpreting courses. And she also talks about her own PhD course. So that's coming up. This is about our work with speech language therapists. Every year, my health interpreting students and I go to another university and we work with speech therapists. Very interesting because the ethics are different. We have to actually give meta-linguistic commentary. This is Eunice's PhD, exploring health interpreting for Chinese immigrants in Aotearoa, New Zealand. She went to that big hospital that I worked in and observed Chinese interpreters in action. And then she interviewed Chinese patients, health professionals, and interpreters. So you can see, in spite of my very busy, heavy teaching load, actually for a professor, I do quite a lot of publications. Here's the Chinese book. And then here's Thrown in the Deep End. So that's on interpreting paramedic language. And this is about semi-authentic practices. So what you can do to help student health interpreters learn about the health setting without them actually being there. So here's some of the titles of the publications on idiomatic language. An Achilles heel, Thrown in the Deep End, and I think we've also got Missing the Plot. Now I'm going to try and play this. I hope it works. But this is John Campbell. He is a really well-known New Zealand TV host, and he has a brother-in-law who's not from New Zealand. And in New Zealand, we say, oh, that's cool ass. That means, oh, that's so cool. So it's AS, cool ass ice, big ass. It's not the American pronunciation of a word for bottom, okay? It's just, so anyway, he talks about how his brother-in-law was hearing it and thinking, what does that mean? So it's not what we learn when we're overseas. Hopefully the sound works. Bay will let me know if it doesn't. We did practice this beforehand.
Ineke, translations work when they're literal, don't they? So if we think of the word cow, then it's going to have... But when we're trying to interpret when people are speaking in ways, like when my brother-in-law came to New Zealand and people said something's cool as or big as, and he kept waiting for them to finish the sentence. Cool as what? Big as what? So how do we deal with the vagaries, the idiosyncrasies of particular ways of speaking?
Oh, you just hit the nail on the head there, actually, because what people learn when they learn a language overseas is actually quite formal language. Like I learned, how do you do? When I first
How do you do?
Nobody says it. Hi, how are you?
Yeah.
Not too bad, you know. But people in New Zealand and Australia particularly use a lot of informal language to make people feel at ease.
Yeah.
So, and that is what people don't get taught overseas. So they're flabbergasted.
Yes. So how do we translate that? And we're going to come back to you. But Ineke, how do we translate that?
Well, you actually have to be so familiar with both languages. I always say to students, watch Shortland Street. It's absolutely jam-packed with New Zealand idioms. And if you try and figure it out in the context and then find something in your own language that is similar. And if there is nothing, then just explain it, paraphrase it.
Because part of these aren't only language or linguistic differences, they're cultural differences too.
Absolutely.
If we're talking about
absolutely.
Yeah.
So New Zealanders might say to Mustafa, if he's an 80-year-old and he's broken his hip, how are we going, darling? How's our young lady? Now, that would be totally inappropriate in Chinese. You'd have to say, how are you, Mrs. Lee?
Yeah.
I agree.
So that's Mustafa, who's on the Royal Commission of Inquiry into the mosque attacks. So here's the publications, and Achilles' heel thrown in the deep end. You see, we had some fun thinking of those titles and then missing the plot. And that's why I found that little cartoon. No, you haven't lost the plot. You never had it. In other words, you were always clueless. Okay. So we need to have situated learning. So really, when I came to New Zealand in 1989, we actually went to the courts to learn court interpreting. And that was after hours, so the courtrooms were empty and, one person would be the judge, one person would be the interpreter, etc. That was really cool, actually, I have to say. So our students go to the courts and they observe interpreter-mediated court hearings, sometimes trials. They're mostly open to the public. Of course, the family court isn't, that's private, but most court hearings, unless they involve very young children who've suffered abuse, but most court hearings will be public. And you can sit on the public gallery as an interpreting student. You cannot take notes because they might think you're a journalist and you have to sit in the press gallery. So what we do in class is we have managed to get hold of some audiovisual clips of courtrooms, court trials in New Zealand, where there was what you call cross-examination or examination in chief. And that is really aggressive because what really bothered me, and at this stage, I wasn't teaching legal interpreting. It was my friend who's a lawyer. Is the student said, oh, we don't need to know that. Oh, we don't need to know that. And I'd say, yes, you do need to know that. And I thought, hang on a minute, let's do this. Let's give them these audiovisual clips. And they'll go, oh my goodness, is this what we have to interpret? Yes. And then again, I got funding and I got the students to interpret these audiovisual clips. And we, with their permission, of course, we looked at their recordings. And for the Chinese interpreting students, my former PhD student, Wei Tang, you can see his name there. He did all the analyses of the Chinese question, the way that the court questions had been interpreted, because they are used by lawyers to undermine the credibility of the witness. and very difficult to translate into Chinese or other languages, especially with double negative, no? So here's some of those publications. And you can see, that must be another one with Wei Tang, 2017. Don't know where it is now. Maybe it's on the next slide. But you can see we had a lot of fun with that. And these are really interesting. If you're teaching legal interpreting, have a look at those articles, because there's all sorts of examples how they were interpreted in Chinese. And then he did the analysis of Chinese question types, you know, dui bu dui, you know, those sorts of things, hao bu hao, and then ma, and yeah, all sorts of things, and how it doesn't actually quite fit the way that the English question was asked. It's really interesting. So look at the ones where Wei Tang is a co-author, and it's strange because there's an extra one that was there and I can't see it now, but it's 2017, 2018 we published those articles. So yeah, we got funding for students to practice with real television clips, and of course technology advanced very quickly, but initially we had to ask a technician to manipulate those clips. Now with GoReact we don't have to do that because the students can just pause it themselves and interpret. We could only do the research once the academic year was over, because it's unethical to do research in New Zealand. It's unethical to do research with your own students because they can't say no, because they'll go, oh, I can't, Ineke's asking, I can't say no, because she might give me a low grade. I would never do that. It's very unethical, but I always have to wait till the next year. And when they're no longer my students, they can feel free to say yes or no. And most of the time they say yes. Sometimes they say no. It's fine. There's absolutely no consequences. So interpreting the language of paramedics, I thought that was one of, because you know me, I'm a health professional, so I just love that. And I've analyzed the use of informal language. When was it actually used? And there was 3 different reasons, main reasons why they would use, or situations in which they would use informal language. And the first one would be to elicit information, because of course paramedics arrive, they have to find out what's going on so they can start treating. And so they ask questions, they have to get that information, but the patient is in stress, bystanders are stressed, everybody's stressed. When people are stressed, they don't give you a straight answer because they can't think properly. Believe me, I've worked in hospitals, I know. So that is why people like myself and others use informal language to get people at ease, and then they'll answer our questions, which give us the information that we need. So this is an 85-year-old female, the top one. She's broken her hip. Last year, she broke her right hip. This time, it looks like she's broken her left hip. But what does the paramedic say? What has our young lady done? It looks like you've done the other one this time, darling. So very informal, also giving information very informally, so it doesn't hit as hard. Because people hear medical terms and they go, oh, you know, don't know what you're talking about. So this is to elicit information in an informal way. And then, of course, our young lady, you can say to a New Zealand lady, if you're a young male paramedic or even an older paramedic, but if you say this to an older Chinese lady, she would be, if you interpret this as young lady or our young lady, she'd probably be quite offended, and you wouldn't get the answer. So it's also culturally inappropriate in some cases. So I always tell my students, if you feel it's culturally inappropriate, then just say Mrs. Lee, or just address them the way they expect them to be addressed. And interestingly, after some time in New Zealand, actually, older Chinese migrants really like the way they are being addressed. They get used to it and they actually start to really like it, because they say people are so friendly. They're not really barking instructions at them. Giving instructions, you reckon you can give us a hand to get on the bed? And even this was misinterpreted by some of our students. And then what I call softened representations of medical reality. And usually I do it myself. I'll just pop out, I'll just pop this and pop that in, I'll pop that out. I'll just, so it's minimizes it. It's like softening it. And the worst one I saw on or heard on in that program, in that clip that I gave to the students was, you need to get into the hospital to get a bit of a chest x-ray. And I thought, which bit? Which bit of a chest x-ray? But it's just minimizing it. I just need you to hang in there, all right? And this lady, the bottom one, because your breathing is pretty ordinary, isn't it, Dal? Dal for darling. And actually, this woman just about couldn't breathe at all. She had asthma and swine flu. So she had pneumonia and asthma, which is really bad. And they minimized it completely by saying, your breathing is pretty ordinary, when actually it was totally not ordinary, just to make her feel a little bit more at ease. So again, same with the legal interpreting students. And this man is actually an ambulance driver. This is a police officer, and you can see the aggressiveness of the way the questions are asked. You can see the police officer is going like this, and the ambulance officer is very uncomfortable. So because that can be really, really brutal and very difficult for us, because the lawyers, they sit around in their hotel room or wherever they are, they think about the exact way they're going to ask the question. And then they read this very carefully drafted question. They say it in court, and we are Johnny on the spot, having to think of a way to say it in Dutch or Chinese or Spanish. Incredibly difficult for us. And often the questions are aimed for the lawyer to have very tight control over the way the question is answered. They basically try and back people into a corner so they can only say yes or no. And of course, they often use double negative. But you wouldn't deny that, would you? And you know, if I ask a double negative question to people in many languages, they'll say yes, when the answer in English would be no. You wouldn't deny that, would you? No. But in Chinese, I might say yes, and then they've got you. It's very difficult. I think interpreting in court is something that's really, really difficult. And they always say to us in New Zealand, you must interpret my questions verbatim, but how can we? Because it'll be pure nonsense. I sometimes say to lawyers, look, verbatim, okay, so ni hao, shall I do that verbatim? You good? That's verbatim. It doesn't make sense when actually the person is just saying, hi, how are you? Right? Ni shafan lama. Have you eaten rice? No, how's it going? Right? Verbatim is nonsense. So we can't do verbatim. And here you go. You can see Wei Tang. He's from Taiwan. He's a Chinese linguist now teaching at the University of Canterbury. He's a translator and interpreter as well. So we showed the students clips from 2 trials. The David Bain retrial. He was accused of killing his entire family, his father, mother, and 2 sisters and younger brother. And there was a retrial because he said he was not guilty. We got the students to interpret the first time they saw the clip, because that is what happens in court. And when you go to court in New Zealand, you get almost no information about what you're going to be interpreting. And they say that's because of the law. And of course, we actually paid external assessors to give students external feedback on how they had interpreted, because the aim was always to get them to learn. And then we did an analysis of the questions and how the student had interpreted them into Chinese, Korean, and other languages. But because Wei Tang is a native speaker of Chinese, he did a fantastic analysis, I have to say. And we're using those findings now. So our current students really like Wei Tang's analysis of, you know, how it's actually, if you interpret it that way in Chinese, that is what it means, and it's different to what the English question was. Okay, oh, some good fortune for me. I don't know. Oh, that's right. Okay, I won some Vice Chancellor's Teaching Awards, and the second time I won a Vice Chancellor's Teaching Award, I was able to go to a conference in America, because you get money, but you have to use it for professional development, $10,000. And I saw patient navigators in the healthcare setting for very low literate parents with children, very sick children in hospital. Where an interpreter would actually be no good because they would be interpreting it in correct Spanish or correct Somali, but it would be right over the parents' heads because the parents had no idea how the body worked. So they needed something different and they needed navigators. So I spent 3 months at Seattle Children's Hospital in 2014 looking at the patient navigators. As I said, Spanish is one of my languages, and 2 of the navigators were Spanish speakers. And I don't know why I put the bottom one there, but anyway, in 2020, I was made an officer of the New Zealand Order of Merit for services to interpreter and translator education. And as Bay said, this time I'm a Kiwiback semi-finalist, but the New Zealand Order of Merit, that's a big one. I was really pleased. That's our Governor General. And the man in the top picture in the middle is the Chancellor, and that's my Dean, Professor Pare Keha. He's the Dean of the faculty that I work in. So I went to Seattle Children's, and I found that the navigators were actually doing sort of like unpacking. So they weren't interpreting into Spanish or Somali. They were actually explaining things to a level that they thought the parents could understand, encouraging the parents to ask questions. But sometimes it would actually take months before the parents would really understand what was wrong with their child. And there was very sick children in that hospital. There was also lots of children dying, lots of medical specialties. And parents often didn't follow instructions, but because the doctors were saying it, and the doctors we come back to culture, the doctors might be wearing T-shirts and jeans. And the parents would think, how can I trust the doctor? A young person who's wearing a T-shirt and jeans. That's not a doctor. A doctor is an older person in a white coat, right? So sometimes they had to work with parents for a very long time. And all the navigators had a health background. And you can see some publications on that. And I'll just give you one example. There was a genetics counselor and a couple. And the couple had already had, I think, 1 or 2 children with a very severe genetic defect. And when they tested the parents, it was clear that whatever children they would have the same genetic defect. But the parents had no idea where children come from. So the navigator was with the counselor, and the navigator said, maybe explain it this way. Mum and Dad are making a stew. That's the pot, the stew. And Mum and Dad both keep putting in the same ingredients. And that actually helped the parents to understand that the outcome would always be the same. And that taught me a very important message. That is that doctors and health professionals, we often want patients to understand the full picture with all the detail, but we forget that people will go, my head is full. I can't understand this anymore. This is too much. It's overwhelming. And so we really sometimes just need to drill down, focus on the main elements of the message. What is the crux of the message? What is the main point? And navigators would give input to health professionals, which interpreters, of course, we know we're not allowed to do, but they were. And then the parents would teach back. They say, this is my understanding. And that's a very good way of checking whether people have understood. So that's what I took away, is that navigators are essential. I'm still trying to introduce what I saw in the United States and New Zealand. But they need supervision because it's a very difficult job, and there was lots of ethical issues and dilemmas to do with culture. Sometimes people were homeless. There was all sorts of barriers that were uncovered by the navigators working with these families. But I did some talking card research in New Zealand, and I published on health navigation. Talking cards is actually when an important message is recorded onto a talking card. People take it home, they can play it as often as they like in their own language. And I did that with Cantonese, Mandarin, and Samoan. So here it is. So talking cards at the hospital. they recorded the discharge instructions, because people often forget those. As soon as they're home, it's a stressful situation. They get home and they've forgotten half or the most important things that the doctor had said. So they were recorded on those talking cards, and that's what they look like. My research was about gestational diabetes mellitus, which is pregnancy diabetes, and a special clinic for women with pregnancy diabetes. The Chinese women were very health literate. They listened to the cards and then they said, okay, now what can I do to control this? So they immediately went to the next step. Because if pregnancy diabetes is poorly managed, that can have very serious consequences. Some people say that if you're born to a mother who had diabetes while she was pregnant with you, you have a hugely increased risk of developing diabetes, and at a much younger age than normal. So you really have to watch your intake of carbohydrates. For instance, jasmine rice is almost like sugar, and it's a favorite of many people, jasmine rice. They love it, and yet it's really not very good, and you really need to minimize your intake of it if you are at risk of developing diabetes, type 2 diabetes. So this is my talking cards research. You can see a little Chinese boy kissing a tummy, and that went quite well, but I only got 10 women responding, and they were all Chinese and Cantonese speakers. So they were then interviewed by bilingual research assistants. What was your understanding? What was on the card? Did you listen to it? And what did you find? And most of them said, now okay, that was very clear, but now we want to know what we can do. And some of the cards were actually defective. They didn't work properly. And it was only spoken text. And I personally think that's a bit boring. But there was no uptake by Samoan speaking women at all, which was a real shame, because there is a lot of pregnancy diabetes in New Zealand. So what I learned is you need images as well. So I'm just going to skip through this. So what the end users wanted was not in-depth information about gestational diabetes or even about the medication and insulin, but how can we manage this? And for instance, the plate that you see there, with just meat and veggies, that's probably the best sort of food that women can eat, and go for a walk after a meal. So community translation, I promised I would give you this, and I'm going to finish after this slide, is translation in and for communities. So it has a social function, equal access to information, but we need to always make sure it's culturally appropriate. And most health information pamphlets actually end up in the bin. So I'm still doing research on this, on more fun ways of getting information across. Because it's very important that people really understand their condition and what they can do to manage it. So in New Zealand, we have low literate migrants, we have low literate refugees because they haven't been able to go to school. They've been in refugee camps. So they've missed that whole essential part that we've been lucky to have. And we have low literate deaf people, older deaf people, didn't go to the mainstream schools. But really, if people have a poor understanding of health and how to manage it, they're likely to have shorter lifespans and more long-term serious illnesses like diabetes, high blood pressure, cardiovascular disease, etc. So I'm really still very much working on this. So telling a story, I think, is important. And that's some of my pictures. So I did a whole story about a doctor who prescribed medication, and the guy goes to the pharmacy. So those images are all mine. It's usually elderly people and also older health consumers with limited English proficiency. So, I'm going backwards. That's silly. Sorry about that. And I think narratives, if you tell a story, people don't feel so threatened. It's not like you have to do this or you have to do that. No, you tell a story and people recognize themselves in the story. So that's not actually threatening. So a simple cartoon, clean style, just like Tintin. Tintin is one of my favorite cartoons. And I used to have a little dog like that. His name was Nigel. Tiens, quel curieux goût elle a, c'est tout. This water tastes really strange. That's what he's saying. Okay, some publications, and Bay has this, she has this PowerPoint. Okay, so if you want it, she can give you access to it. And also this has been recorded. So some research suggests that if you want to make pictures for low literate people, stick figures are best. And there's a famous supermarket in New Zealand that uses this stick figure. So otherwise people start to look at, oh, she's wearing red shoes, or she's got earrings in, and that's not the message. So, but I never use stick figures, but yeah, it's supposed to be better. So yeah, I probably can't go through this because I have to stop now, don't I, Bay? It's 4:48 in my time, so it's 11:48 in Singapore.